Hello, everybody. So today in Cuddles online neonatology education, we are going to discuss about the neurological examination of a newborn baby. So we know that neurological examination is important for multiple reasons. One is to assess the gestational maturity of the baby. It is also used for assessing the staging of hypoxic ischemic encephalopathy in a baby who has had asphyxia. And it may be also useful for determining whether the baby had any evidence of bilirubin encephalopathy in case of severe hyperbilirubinemia. The neurological assessment of a baby has a lot of importance, not only for understanding the current status of the baby, but also for the long-term prognostication. Again, in preterm neonates, pre-discharge, it is one of the mandates to perform a thorough neurological assessment. If you have had a baby who is born preterm at 26, 27 weeks, at discharge or at term age, corrected age, it is important to perform a neurological examination to understand whether the baby has attained appropriate neuromuscular maturity. So the sequence for neurological assessment is performed in the following order. The baby's higher mental functions are assessed. Just like we have in a bigger child, where we may use advanced scores like the Glasgow Coma Scale, etc. Even in newborn, there is a systematic way for performing the assessment of the sensorium or higher mental functions. We should be discussing that in detail. B, we do a cranial nerve assessment. We assess all the 12 nerves in sequence from the olfactory nerve until the hypoglossal nerve. So this is part of the cranial nerve examination. Thirdly, the most important part of neonatal neurological assessment is motor examination, particularly assessment of muscle tone. Again, we shall see that in a practical demonstration today in detail. And we do not have the regular assessment of the deep tendon reflexes and other superficial reflexes, at least not all of them, but we have certain primitive reflexes that we all know are prevalent only in the neonatal age group. So we try and elicit the neonatal reflexes. That is the fourth part of the neurological examination. The last part involves assessment of the baby's vision as well as hearing sense. It is important to know that it is difficult to see some parts of the examination in newborn, particularly the cerebellar assessment of the sensory system, etc. But there are some other aspects which are very essential in neonatal neurological examination, particularly the tone assessment. Assessment of vision, assessment of fundus, and assessment of the neonatal primitive reflexes. So with that brief introduction, we shall begin with a brief orientation of the first part of neurological assessment, which is higher mental function. So the first aspect of higher mental function, again, is to assess the sensorium or level of alertness. So normally, if you see the level of alertness or sensorium of a newborn baby, we can't use the other regular scores like GCS system or Glasgow Coma Scale. Obviously, because of the limitations in assessing baby's response to commands, etc., we can't use GCS. So instead, we have three main parameters to comment on level of alertness. These are appearance of the baby, arousal response, and motor response. So in appearance, we comment whether the baby is awake or whether the baby is sleepy or deep asleep. In arousal response, which is arousal to a stimulus, usually in the form of a mild painful stimulus or tactile stimulus, the arousal response of the newborn can be categorized as normal, diminished response. Again, it can be slightly or moderately diminished and completely absent arousal. And the third important aspect is the motor response. In motor response, again, one comments on the quantity of motor response, that is whether the movements were normal in quantity, and the quality of motor response. So based on these three parameters, appearance, arousal, and motor response, the sensorium can be classified as normal, stupor, and coma. Except in normal level of alertness, the baby's appearance is generally sleepy or deep asleep in both stupor as well as in coma. So the further differentiation between stupor and coma is usually based on the quality and quantity of motor response. Now, quantity of motor response is subjectively assessed, whether the baby has normal motor activity, whether the baby is moving all the limbs. So this again is a huge area of discussion. There are scales which assess only the quantity and quality of motor assessment. So there is a gross motor assessment scale, which is used for describing this in detail. But what is also very useful is the quality of motor response. We'll discuss a little bit about this. So 3 parameters indicate that the motor response is of high quality. 1, it should be non-stereotypical. That is, it should not be repetitive. 2, it should be present even after it should be present after a definite latency following the stimulus and should not immediately follow the stimulus. And 3, the motor response normally is habituating. So if motor response is stereotypical, that it is repetitive and is of the same type happening again and again. For example, if the baby is having rowing kind of movements and it is happening again and again, it is of poor quality. And number 2, instead of having a definite latency, if it follows the stimulus immediately, again, it is of poor quality. And thirdly, high quality motor response should normally habituate. That is, after 3 to 5 stimuli, the motor response should no longer be elicitable. If this again doesn't happen, it is considered as low quality movement. The other important part of neonatal behavioral assessment is to use either Prestell's or Breselton's behavioral state to describe the state of the baby. Now, state of the baby essentially indicates the baby's level of alertness or sensorium. Based on Prestell's behavioral state, neonatal behavior is divided into 5 states, state 1 to state 5. So this is based on 3 important variables. One is whether the eyes are open or closed. Secondly, respiratory pattern, whether it is regular or irregular. And thirdly, whether there are gross body movements which are present or absent. So in state 1 and 2, the baby's eyes are closed. That is, this is similar to sleep, in which again state 1 is like the non-REM sleep or deep sleep, where eyes are closed, respiration is regular, there are no gross body movements. State 2 is like rapid eye movement sleep. So it's like a light sleep where eyes are closed, but the baby has irregular respiration and there are gross body movements which are present. In both these states, the baby doesn't have any cry. State 3 and 4 are similar to 1 and 2, the only difference being that the eyes are open. So state 3 can be considered as quiet awake state. State 4 is active awake state. So in both these states, eyes are open. And in 3, similar to state 1, the respiration is regular. There are no gross body movements. So baby is just quietly awake. There are no movements. Baby's breathing is regular, but eyes are open. State 4 is similar to state 2 with the difference that eyes are open. So the eyes are open, respiration is irregular, and gross body movements are present. In both these states, again, the baby is still not crying. In state 5, it is nothing but state 4 or 2 with the addition of clear-cut vocalization or cry. So this is important for identifying 2 things. One is normally a baby with intact sensorium should have normal state to state variability. So state should change from one state to another. If persistently you find the baby to be in the same state, this is a sign of abnormality. So if you see a baby who is currently in state 2, the baby may move 20-30 minutes later to state 3 or 4 and vice versa. If this doesn't happen, it is abnormal. Secondly, the best state for performing a neurological examination itself is either state 3 or state 4. It is difficult to do examination in state 1 and 5. The other behavioral staging system, which is used for describing behavioral states, is also Breselton states. It is kind of slightly different from the Prestell's state. Both of them have a very subtle difference. So in Breselton's, you have 6 states instead of 5. State 1 is similar to Prestell's state 1, where there's deep sleep with regular breathing. State 2 of Breselton is light sleep with eyes closed and rapid eye movements are present with irregular respiration. State 3 of Breselton, eyes may be open or closed and the infant appears to be dazed and reacts to stimuli with change in state and smooth movements. State 4 of Breselton, the baby is alert with bright look, but again minimal motor activity. And state 5, eyes are open with considerable motor activity. So state 4 of Prestell is divided into state 4 as well as 5 in Breselton, in simple words, in summary. And state 6 of Breselton is again a baby with active cry, which is difficult to break through, similar to Prestell's state 5. The other important aspect of higher motor function assessment is assessment of the habituation. Now, what is habituation? It means that if there is a stimulus that is provided, and if it is repeatedly provided, then after the initial 3 to 5 responses, the response will become extinct. This is normal habituation. This must be normally present in a baby. So habituation is considered to be abnormal either if it is a completely non-habituating or recurring even after 5 stimuli, or if there is very early habituation. So if it is happening even after 1 or 2 stimuli, that is also quite unusual. Habituation can be tested by giving either a tactile stimuli in the form of glabellar tap, or it can be given as an auditory stimuli by ringing a bell, or a visual stimuli by showing a bright object, wherein the response of the baby will be in the form of a blink. Next is consolability, which is the measures that need to be taken to console a crying baby. Either the baby may get consoled spontaneously or by talking to the baby. Sometimes you may need to put your hand on the baby and gently pat the baby. Some babies may need to be picked up and held close to the body. And lastly, there may be unconsolable cry, wherein whatever we do, the baby's cry may not be consoled. In addition to these, the quality of cry as well as the nature of the voice is also important. So normally we know that all newborn babies may spend considerable time in the form of crying, but the character of the cry and also the quality of cry gives us some information about the baby's neurological intactness. So in conditions like meningitis, inborn errors of metabolism, or in hypoxic ischemic encephalopathy, the baby may have a very weak cry as well as decreased quantity of cry. On the other hand, the baby may have continuous abnormal, high-pitched and irritable cry when there is an irritant focus in the CNS, either in the form of meningitis or a subarachnoid bleed, or in a baby with kernicterus or bilirubin encephalopathy. So with this introduction, we will go to the demonstration of the higher mental functions in the baby. So let us now take up this baby. So we begin by taking all the sterile aseptic precautions, never do harm. Always undress the baby only as much as we require for that part of the examination in order to prevent hypothermia. So first of all, as we discussed, we comment on the higher mental functions. So what is this baby's state? So we just saw this baby having irregular respiration. And just while we were undressing or removing the blanket, the baby had some gross body movements. But the eyes of the baby, as you can appreciate, are closed. So based on the 3 parameters, eyes, gross body movement, and respiration, this baby will fall into state 2 of Breschel's behavioral state. So eyes are closed, but the baby is having what looks like rapid eye movement sleep. So it is active sleep. That is where we are able to see gross body movements as well as some sort of irregular respiration. Normally, we should see state-to-state variability within our few minutes of neurological assessment. Even under Brazelton's behavioral state, this baby state will be stable. Now, if we have to comment in terms of the baby's sensorium based on the initial 3 parameters that we saw, the appearance, arousal response, and motor activity. So, as of now, the baby seems to be asleep, but this baby possibly might be arousable. So let's see what happens when we give a stimuli. So definitely the baby is responding by form of withdrawal, and the baby is moving both the limbs. So this baby is definitely arousable. We also saw some motor activity. So it followed our stimulus with some kind of definite latency. Also, after we stimulated the baby repeatedly, we will find that it habituates after a while. So we can say that this baby is having normal level of alertness based on these 3 parameters. Although the baby appears asleep, the baby has arousal as well as high quality motor response. As of now, the baby is not crying, so we cannot assess the consolability of the baby as well as the nature of cry. So let us see if we can assess habituation for this baby with a glabellar tap. So typically when we assess habituation, we can either assess tactile stimulus by giving glabellar tap. Usually the finger of the examiner must be brought from behind the baby so as to not stimulate the visual habituation. And we give a pat over the glabellar region, usually at the frequency of 1 per 5 seconds. So this baby hardly had any response. Usual response that we expect would be in the form of a blink. Both the eyes, the baby would generally blink. And after we give the stimulus for 3 to 5 repeated times, the baby would generally get habituated. One can also check the habituation by using the Warmer's light, by by blinding the baby's eyes to the light, and then repeatedly you can expose the light, or we can use a torchlight for doing this. Again, this bright visual stimulus must be given once in 5 seconds, and after 3 to 5 cycles, whenever the baby is actually blinking, we may expect the response, or we can ring a bell that can be kept at a distance of around 12 inches from the baby. So this is for assessing the baby's habituation. The other response, the other thing that we see is consolability, cuddleability. Cuddleability is similar to consolability, but it can be also elicited in a non-crying infant. So we will now move on to the other parts of the neurological examination. So the second part of the neurological examination is the assessment of the cranial nerves. So we have 12 cranial nerves and we do this one by one. So for the olfactory cranial nerve, generally we take a cotton swab that is dipped in mother's milk, and this can be brought close to the baby, and we will see whether the baby tries to root for this or tries to turn the head towards the source of this smell. Usually a swab dipped in mother's milk is what is preferred. Now, the second important nerve is, as you all know, the optic nerve. Now, optic nerve, how do we assess? So we use a torchlight to elicit the pupillary response. So we all know that the pupillary response, the afferent is the optic nerve and efferent is the olfactory nerve. So while eliciting pupillary response, the torchlight must be brought from the lateral aspect of the baby's face, and gradually should be brought towards the midline. So when you want to avoid the consensual light reflex, it is a good idea to actually have your fingers over the nasal bridge so as to prevent stimulation of the other eye. So the reflex that is expected is pupillary constriction. The afferent is second nerve, and efferent will be the ophthalmic branches of the third nerve, the olfactory nerve. So this response is generally elicitable from 29 weeks of pregnancy itself, from as early as that, although we may start seeing a very easily elicitable response a little later. The other things that can be seen are, by around 32 weeks, the babies will start having blink response to bright light. And we see something called as a dazzle reflex. When there is bright light, the baby may automatically close the eyes as well. So all these indicate the presence of an intact optic nerve. While talking about the optic nerve, it is also important to comment upon the size of the optic nerve. So normal 3 mm, and there are some where we see bilateral increase in size of the optic nerve. That is bilateral dilatation, mydriasis of the pupil. This can be seen when the baby has a hypoxic ischemic encephalopathy. Especially stage 1, there will be sympathetic overdrive and mydriasis. There will be bilateral dilatation. This can also happen if there is accidental injection of local anesthetic into the baby's scalp. On the other hand, if there is bilateral meiosis or pinpoint pupil, this can happen either with a baby who is on morphine or opioid analgesics, or it can happen in stage 2 of HAE, that is when there is parasympathetic overdrive. If there is asymmetry in the pupillary size, like when there is unilateral meiosis, we have all heard of the Horner syndrome, which is due to cervical sympathetic injury. So if cervical sympathetic nerve tracts get injured, there can be unilateral meiosis or Horner syndrome.
Likewise, if there is unilateral abnormal mydriasis, this can very commonly be seen if we have instilled dilating drops for an eye assessment, but this can also happen if there is a third nerve palsy on that side. If there is a large subdural bleed also, there can be asymmetry of the pupillary size. So asymmetry of pupillary size is always something that needs to be noted, and size of pupil as well as pupillary reaction both must be corrected. In bigger children, it is possible to elicit the accommodation reflex, wherein we bring an object quickly towards the baby's eyes and try to look for pupillary constriction, but this is generally more difficult to elicit in newborn babies because they generally close their eyes due to the menace reflex. So we may not be able to appreciate the accommodation reflex. Pupillary reflex will be generally elicitable in most of the babies. So two things should be avoided is never shine the torch directly into the baby's eyes. Always bring it from the lateral to the medial aspect. Newborns physiologically have photophobia, so it might sometimes take some while for eliciting the pupillary reflex because babies normally tend to close their eyes. Now moving on to the third nerve, also we have indirectly assessed by the efferent part of the pupillary reflex. So when it comes to the extraocular muscles, the nerves, the cranial nerves 4, 6, as well as 3. 3, 4, and 6 are responsible for extraocular movement. So we generally look for the doll's eye movement in a baby who is comatose or a baby who is asleep, stuporous also, we can elicit doll's eye reflex. So we will have to actually open the baby's palpebral fissure. And while we turn the baby towards one side, we will see that the eyes will move towards the opposite side. So in all babies, doll's eye movement will be easily elicitable. Unlike in bigger children and adults, it will be elicitable from 25 weeks to around 2-3 months. We know this is a brainstem mediated reflex. Usually in bigger children with intact sensorium, because of the intact cortex, the doll's eye movement will generally not be elicited. Other than this, we should also be able to see the normal conjugate movement of the eyeballs whenever the baby's eyes are open. So if there is lack of conjugate movement of the eye, or there is some kind of gaze-related palsy, this could indicate problem in the extraocular muscles. One of the common nerves that tends to be involved is the sixth nerve, which supplies the lateral rectus. So it is responsible for abduction of the eyeball. So having finished these 3 nerves, we'll also see what can be done to elicit the intactness of trigeminal. So trigeminal is a cranial nerve. We know that it has a motor part and a sensory part. So when it comes to the motor part, the motor part of the trigeminal nerve can be tested by testing the muscles of mastication. So generally when we insert my hand is already clean. So if we try to insert our hand into the baby's mouth, term baby generally tends to not only suck, this baby has begun to suck already, but will also bite the finger. Usually the bite will be so tight that it will be difficult to pull out the finger. This bite indicates the intactness of muscles of mastication, particularly the masseter muscles, which are supplied by the motor part of the fifth nerve. The sensory part of the fifth nerve is tested by looking into the corneal blink reflex, corneal as well as conjunctival. So for testing this, we need to get a sterile ball of cotton. So you can make sure that this is clean cotton, and a small part of this is made into a little pointed kind of roll of cotton thread. And for testing the corneal reflex, this cotton ball is brought gently to the lateral part of the limbus of the eye, after which the baby tends to blink. So this reflex, the afferent is the sensory part of the trigeminal nerve, the ophthalmic branches of trigeminal nerve. Efferent will be from the seventh. So this can also be tested by introducing this cotton ball onto the lateral aspect of the palpebral conjunctiva. So this tests the sensory aspect of the trigeminal. So trigeminal nerve is indirectly also responsible for eliciting the rooting reflex, which also requires a sensory stimulus. This baby is possibly deeply asleep, but rooting reflex generally is elicited by stroking the lateral aspect of the baby's cheek, after which the baby generally will turn the head towards the finger. I may sometimes open the mouth. And when the baby is really hungry, this baby is maybe marginally beginning to root. The lips will actually deviate towards the source of the rooting, and sometimes even tongue protrusion would be there. So we have discussed the motor part of the trigeminal nerve for the muscles of biting, and the sensory part in the form of rooting, the corneal as well as the conjunctival bleed. Then we come to the seventh nerve. So seventh nerve, we all know the facial nerve. Sensory part of seventh nerve, it only supplies the posterior third of the tongue, very difficult to elicit in a baby. The motor part of facial nerve, it is easy to identify when it is inborn. So what all we will see if the facial nerve has, unilateral involvement, we will have to look for the intactness of the nasolabial fold. This is the nasolabial fold. This, when absent, indicates that there is lack of facial nerve sort of function. And along with that, we will look at the size of the palpebral fissures on both sides. There will be inability to close the palpebral fissure completely if facial nerve is involved. And there can be difficulty in both in the sucking, there may be continuous drooling, and eventually the baby will start to show deviation of the angle of mouth to the normal side. So imagine if this baby had right-sided weakness of the facial nerve, what all we would see? We would see the doll's bells phenomenon. So whenever the baby attempts to close the eyeballs, we will see the upward movement of the eyes because of the inadequate closure of the palpebral fissure on the involved side. There will be deviation of angle of mouth to the left side. There will be lack of nasolabial fissure, and there can be drooling of saliva as well. Now, if there is complete involvement of one half of the face, it indicates ipsilateral element facial palsy. If there is involvement only on the lower side of the face, it indicates contralateral UMN facial palsy. So if you see UMN facial palsy, it might be part of brain stem or nuclear involvement as seen in HIE, or part of 6th and 7th nerve involvement like in Mobius syndrome. But element facial palsy, usually it's traumatic in etiology, and very rarely it can be due to viral infections of the ear, wherein because of the edema, the facial nerve can get compressed in the stylomastoid. Now, we move on to the eighth nerve. Eighth nerve is the vestibulocochlear nerve, which is responsible for hearing. So for hearing, we just look at the behavioral response to loud sound, like when we clap, or if we ring a loud bell. This baby seems to be in really deep sleep. The baby should have some sort of blink, or the baby might have some kind of motor disturbance. This is the normal response to eighth nerve. And 9th, 10th, 11th nerves, these are all part of the lower cranial nerves, which are responsible for swallowing and for deglutition. So this need not be separately tested generally in a normal newborn. What we usually see is if the baby sucks, swallowing, and coordination between suck and swallowing is normal, it generally indicates that the 9th, 10th, and 11th nerves are intact. If there is a baby who has feeding issues, there is drooling of saliva, there is pooling of saliva, pooling of secretions, nasal regurgitation of feed, baby who is unable to swallow, this baby needs to be evaluated for the functioning of the 10th, 11th, and the 9th nerve. Otherwise, generally, we don't test them. And we may test them by doing a proper gag reflex. Usually, that is not required. Pulp nerve supplies the hypoglossal, that is a hypoglossal nerve that supplies the tongue. So usually, again, since the baby wouldn't protrude the tongue, this is also difficult to elicit or examine in a newborn baby. When we have an opportunity, when the baby cries or protrudes tongue, we can look for whether there is any asymmetry in the movement or deviation of the tongue to one side. So now we move on to the most important aspect of the baby's newborn's neurological assessment, which is the motor assessment. Motor assessment, as in a bigger child, begins with the assessment of bulk and comment on the muscle power and the tone. Now, bulk, you can see it's very difficult to see a problem in bulk because generally newborn period, unless the baby had a chronic neuromuscular problem, we don't see atrophy. So grossly, you can comment that the bulk of this baby's both sides appears to be symmetrical. We generally don't see problems in newborn babies involving the bulb because the problems are usually acute in origin. Coming to the power, now how do we elicit power? In bigger children, we know that power is graded into 5 different grades. If there is no movement, 0, 1 is when there is flicker of movement, 2, there is some anti-gravity movement, but the baby may not have movement after eliminating gravity. Without eliminating gravity, the baby may still have movements. When the baby has a power of 3, we say that the baby has anti-gravity movements. 4 is when the baby has adequate anti-gravity movements and is able to do movements against resistance, but it is slightly diminished. And 5 is the regular power when the child can do movements against resistance, against the examiner's resistance. Since we can't check power against resistance in newborns, we can only comment whether the power is below or equal to 2/5 or more than 2/5. So this baby, you can see, is definitely having movements eliminating gravity, and is occasionally moving the limbs even against gravity. Like he lifted the left leg lower limb now. So it is power is 3/5. So now we also had a chance to get the baby's cry. So the cry appears to be quite normal in the quantity and quality. Moving on with the examination. So let us go on with the important assessment of muscle tone. So muscle tone again can be commented with passive tone as well as active tone. Passive tone refers to the resting state of contraction of the muscles, usually commented by the posture as well as some animals in the lower and the upper. So let us look at the one way. We'll begin with posture. Posture is this baby's resting state. Now, as you can see, the baby's limbs are extended. So there is some degree of flexion at the lower limbs. There is some dorsiflexion. The baby's limbs are not completely dropping down. There is partial flexion of the baby's knees. So the tone of the baby usually progresses in the caudalocephalic direction or centripetal direction. In a, say, 28-weeker or below, the baby will be completely extended. Both the limbs will be completely extended, including the feet, the ankles. After that, with every 2 weeks, there is progressive flexion starting from the lower limbs. Initially starting with ankles, there will be dorsiflexion. Then the baby starts to have flexion at the knees, then flexion at the hips. At this point of time, there begins some flexion at the level of the upper limb, the knees, and then you can see now this baby is also attempting to flex the hip. The baby is bringing the legs upward. After around 34 weeks, the baby also develops adduction at the level of the hip. So both the lower limbs, they turn inward like this. Around this time, there is progressively more flexion seen at the shoulder. Finally, by around 38 to 40 weeks, the baby develops complete adduction of both the lower limbs, and the baby would keep the lower limbs close to each other, like in a typical 38, 39, 40 weeks baby. So there is progressive increase in tone from the caudal region to the cephalad region. This is the normal progression of posture. So now looking at this baby, this is actually a term baby. But when you look at the posture, it looks like that of a maybe around 34 weeker, because there is some flexion at the hips as well as the knees, but we could not see much of adduction at the level of the hips. So if there had been adduction, the baby's limbs would have come to the midline, which this baby didn't demonstrate. So possibly there is some degree of involvement of the passive tone because there is a lag between the posture-based maturity as well as the actual maturity of the baby. Now, this baby is now come into state 4. The eyes are open. The baby has irregular movements of the body as well as irregular respiration. So this baby also has demonstrated state-to-state variability. Now let us see how many of the passive tone angles we can demonstrate. We'll begin with the upper limb. In the upper limb, we comment upon 3 things: arm recoil as well as square window and scarf swing. So we'll start with them one by one. You should just hold. So let's begin with the arm recoil. So how do we do this? We gently kind of flex the baby's arm. This can be done both sides together or one at a time. So flex, for some books say 15 seconds, some would say 5 seconds. So keep the arm in flexion. Then briefly extend and then release. So this baby had only this degree of recoil of the arm. A normal full-term baby, after we do the arm recoil, flexion, brief extension, should have complete recoil with the palm coming back to the baby, is almost touching the baby's face. This is 180-degree recoil, which is common. So this baby did have recoil, but it was not a complete 180 recoil. Next thing is we look at the square window, wherein we try to flex the baby's palm against the forearm from the volar aspect. And we comment on the angle between the forearm as well as the palm. So this angle between the forearm and the palm normally approaches 0 degrees or is less than 30 degrees in a full-term baby. So this indicates complete laxity of these ligaments. So this baby's angle would possibly be around 30 degrees. So this is considered more as a marker of ligament laxity than tone. The more premature the baby is, the greater will be the angle. So in a preterm baby, this angle might approach almost 90 degrees. Whereas full-term baby, it would be almost 0 degrees. The next one is scarf sign. So scarf sign typically try to avoid a limb which has cannula, etc. So ensure that the head of the baby is in midline. You are assessing the passive resting tone of the muscles of the shoulder girdle. So hold the hand by holding the baby from the palm, and then gradually nudge the baby's hand towards the opposite side, making sure that you should not lift the shoulder completely from the baby's pouch. So note the position of the elbow. Some people would also nudge the elbow using this finger. So this baby, without raising the shoulder, is possibly able to bring the elbow just around the mid clavicular line or around the nipple line. Normally, in a baby who is crossing around 36 to 38 weeks, the scarf sign would completely move to the opposite side, or it should cross the midline of the body. The more premature the baby, it will cross the midline. The more mature the baby, it will be restricted to the axillary line because of the increasing resting tone of the shoulder girdle muscles. So I'll repeat again. We keep the baby's head in the midline, and then we hold the baby's palm and then gently pull the hand towards the opposite shoulder, taking care not to lift the shoulder completely, and note the position of the elbow with respect to the midline. So in this baby, it is not completely crossing the midline. It is possibly reaching until the nipple line. So these are the three maneuvers: the square window, scarf sign, and the arm recoil that are used for assessing the passive tone of the upper limb. Now we move on to the lower limb. Now when it comes to the lower limb, we are going to note the popliteal angle, the adductor angle, as well as the heel to ear sign. So ideally, the baby should not have a boundary. The diaper also could be opened. Now, while testing the popliteal angle, again, we need the head of the baby to be in the midline. Why do we keep the head in the midline? This is to prevent activation of the asymmetric tonic neck reflex. If ATNR is active, then whichever side the baby's face would be turned to, there would be extension or increase in the extensor tone of the ipsilateral upper and the lower limb, and flexor tone of the contralateral side to which the occiput is facing. So in order to prevent this asymmetry, we do not allow the baby's head to be turned to one side. So for doing popliteal angle, you can do it either both at the same time or one at a time. We generally keep the baby's knee, like a knee chest position, on the baby's abdomen. In this position, first we allow the baby to settle down and then gently extend the baby's knees as much as you can without resistance. So this is all I'm able to do in this baby without resistance. Beyond this, if you try to do forcibly, we'll end up lifting the baby's pelvis, which is not recommended. So never lift the baby's hip area from the couch, from the bed. So this baby's knees are both placed on the abdomen, and gentle extension of the knees as much as the baby can permit. So we can do it even one at a time. Fix this knee and then use your finger to gently extend the knee, keeping your hand below the patellar tendon. Below the tendo Achilles. So this angle would be roughly around 90 degrees. In this baby, this can be precisely assessed by a goniometer. This can be done one leg at a time, which is called as Dubowitz method, or both the legs at a time, in this fashion. Stabilize the knees on the abdomen. Allow just a second for the baby to stabilize or calm down. Then gently extend the knees with your thumb just below the tendo Achilles. This is called as Amilteson's method when we do both at a time. Now, what do we interpret this from this? So the popliteal angle is used for assessing the passive muscle tone of the knee flexors. So the hamstring muscles. So we should generally be able to see that it is less than 90 degree in a term baby. This may be falsely elevated if it is a extended breech delivery for the first around 48 hours. The baby can have an abnormally extended popliteal angle, although the baby may have normal neuromuscular maturity. So two important precautions while doing popliteal angle are, one, the head should be in midline to prevent ATNR. And number two, while doing popliteal angle, never lift the hips from the level of the baby's couch. If you just lift the baby's hip, you can see you get even a much higher popliteal angle, but this is not correct. So this will give a false assessment as if the baby has hypotonia. So ensure that the baby's hips are resting only on the bed. So popliteal angle should generally be symmetrical on both sides. Asymmetrical popliteal angle can be a sign of IVH. So the normal progression is in an extremely preterm baby, the popliteal angle can be even as high as 180 degrees. It becomes lesser and lesser with increasing maturity. It would be around 120 degree in a baby who is 33, 34 weeks. And term baby, it would be generally below 90 degree. The next angle, which is quite similar to popliteal angle, is the heel to ear sign. Here we lift the baby with both the feet and we stabilize the hip. You may have your fingers placed over the baby's perineal region and then gently move the baby's feet towards the body. So this is all I am able to do without resistance, and we note the landmark of both the feet. So the landmark that kind of describe against whether we were able to move it until the groin, the umbilicus, the zippy, or sometimes until the suprasternal notch or the baby's chin. The more preterm baby, we would be able to lift the legs completely towards the chin. The more full-term the baby is, it would only reach the inguinal folds. So I'll show it again. Unlike the popliteal angle, we don't rest the baby's knees on the baby's abdomen. We suspend both the feet together with our hand, stabilize the hip so that the hip is not lifted upwards, and then gently nudge the feet towards the baby's body as much as we can. In this case, it is between the groin and the umbilicus. The third maneuver is the dorsiflexion angle. This is the angle that the dorsum of the foot makes against the baby's sort of shin of the tibia. So again, the dorsiflexion angle helps us to get some idea about the laxity or the tightness or the baseline tone of the tendo-Achilles tendon. So normally we will be able to almost completely dorsiflex the foot in a full-term baby. So inability to do complete dorsiflexion again might indicate some tightness of the tendo-Achilles. So I forgot to say that in heel to ear sign, we are testing the tone of the posterior hip flexors against the popliteal angle, where we are testing the tone of these hamstring muscles. Okay. The other angle is the adductor angle. So this angle is useful for assessing the baseline state of contraction of the adductors, the hip adductors. So we have the gracilis and other adductors, which are hip adductors. So these group of muscles are tested using the adductor angle. Again, important to keep the baby's head in the midline. Here, we will need to completely kind of extend the baby's legs. Sometimes you may have to just give some time for the baby to calm down. Once the baby does this, completely abduct until the point the baby is resisting. Now, the baby is just about to begin to cry. So this is again around 80 to 90 degrees. So usually the term baby's adductor angle must be 40 to 80 degrees. So extend the knees, keeping your finger over the parallel to the baby's feet, and gently abduct the hip until the point the baby just has pain or begins to show. So these are all the maneuvers to assess the passive tone of the lower limbs. While doing all these steps, it is important to ensure that we don't violate the principles of developmentally supportive care, causing minimal pain to the baby and keep the baby warm also. So we have assessed so far the passive tone overall by looking at the posture, where we saw that this baby has minimal dorsiflexion, flexion of the knees and the hips, and some flexion of the upper limb, but no adduction at the hip, which is generally between 34 to 36 weeks. And lower limb tone, we looked at the following manuals. The popliteal angle, which is 90 degree, adductor angle, which was 40 to 80 degree, and heel to ear sign, where the landmark just reached around the umbilicus. Upper limb, scarf sign didn't cross the midline for this baby. Square window was around 30 degrees. And we looked at arm recoil, which was around 90 to 100 this baby. So we have so far looked at the passive tone. We also comment on the tone of the trunk by looking at the ventral and the dorsal limb curvature. So ventral limb curvature is the degree of ability of the baby's body to be curved, incurved ventrally. And in the dorsal limb curvature, we just turn the baby usually to the side. And then we nudge the baby's trunk backwards. Generally, the ventral limb curvature is easier than the dorsal limb curvature, like we saw in this baby. If you see the reverse, wherein the ventral limb curvature may be difficult or limited, it might indicate presence of extensor hypertrophy. Now we'll quickly assess the active tone. Active tone assessment. I think this baby is already hungry. We'll quickly look at the manuals. So there are a few important things in active tone. The assessment of neck flexors and neck extensors. The second, this is assessed by the pull to sit manual. Then we have assessment of the vertical as well as the ventral suspension. So we'll first look at the assessment of the pull to sit manual. So here we assess the tone of the neck flexors followed by the extensors. So gently pull the babies to the sitting position until the head falls forward, and then bring the baby back to the sitting position. So when we do this manual, pulling to the sitting position, appreciate the contraction of the sternocleidomastoid muscles. You can see that the muscles are becoming taut, which means the neck flexors are trying to flex the baby's neck. Briefly, the baby's neck comes to the midline, followed by falling backwards, after which the baby's neck extensors, if active, will bring the baby's head back to the position. So generally, we expect that when you do this manual for a newborn baby, you generally will assess the tautness of the sternocleidomastoid. Briefly, the baby's head will come to the midline, and then briefly it will fall forwards. And because of the neck extensors, again the baby's head will be brought back to the midline. Then we do the vertical and the ventral suspension. So for vertical suspension, we suspend the baby from the hand. Look for any slippage. So you can see this baby is not having any slippage from the shoulder girdle. And this is the ventral suspension. So here you can see that the three things that are to be appreciated: any degree of limb flexion. So this baby has very minimal lower limb flexion. The back is completely rounded. And this baby is not making much attempt to bring the head to the midline, to the plane of the body. So three things. We should see if the baby brings the head to the plane of the body, whether the back is rounded, and whether there is any attempt for lower limb flexion in the vertical suspension. This baby has very minimal knee flexion. It is not completely like that of a ragdoll appearance, but still not complete normal flexion. And head, the baby didn't bring it to the plane of the body. The back is completely rounded. So there is some degree of hypotonia that the baby has. The other one is the writing reflex. So for the writing reflex, you may have to align the baby with the examiner's body. You can see that the baby has straightened the lower limbs now, which is the first response at around 32, 34 weeks.
Following this, baby generally straightens the tone, and after around term gestational age, the baby will also straighten the head. So this baby fairly has straightened the legs, but the straightening of the trunk came in little late, and there was very minimal attempt to straighten the head of the baby. So active tone involves these 4 maneuvers: pull to sit for the neck flexors and extensors, the vertical and the ventral suspension, and the writing reflex. The baby has inadvertently exhibited sucking reflex for us. So the next part is the assessment of the neonatal reflexes. The most popular of which, of course, is the Moro's reflex. So this baby being hungry, so usually when we do rooting, the baby will open the mouth and try to suck the fingers. And then when you introduce the clean finger, which I do not want to do now because we have completed most of the examination, the baby will elicit good suck. Moro's reflex, what do? We generally allow the baby's head to fall backward by around 15 degrees. The baby doesn't have a complete Moro's. Usually the response that is elicited will be extension of the upper limbs followed by adduction and flexion. The other reflexes are palmar and plantar grasp. So when you introduce your finger into any part of the palm, generally the baby will exhibit flexion by embracing the finger with all the fingers. So this is generally elicitable from around 28 to 30 weeks and will be brisk in a term baby and possibly until around 3 months of age. Similarly, one can also elicit the plantar grasp, wherein there will be, you can appreciate flexion of the toes around the examiner's finger. If you place the finger on the baby's plantar surface, the baby will flex all the toes as this baby is doing. So this is also one of the early reflexes that will be elicitable. So this again is present for this baby. The other reflex is, of course, the crossed extensor reflex, wherein if you tend to stimulate the baby's, so the baby is actually showing a Babinski's sign now. So when you stimulate the sole, the baby will actually extend the great toe and fan out all the fingers. This baby has an intact Babinski's sign. The other thing babies also do is a crossed extensor reflex. When we stimulate a baby's palm, the baby is supposed to have flexion as well as adduction and extension of the other limb in an attempt to push the examiner's finger. Babies will also generally be expected to have the stepping and the placing reflex. Let's see if this baby is doing. This baby does have a stepping reflex. So you can see that when you just place the baby's palms against the plantar surface against the bed, the baby is attempting to kind of place the feet. And then generally the babies will also have primitive stepping reflex, wherein they will alternatively try to place one feet followed by the other, which this baby is not doing completely. So I think with that, we will thank the baby for allowing us to demonstrate the signs for neurological examination. So now possibly the baby is trying to go into ATNR. So ATNR can be normally spontaneously elicited in full-term babies. You can see this baby is having some kind of partial ATNR with extension of the same side leg to which the head is pointed and flexion of the opposite side leg. In complete ATNR, the baby will also have extension of the unilateral ipsilateral upper limb and flexion of the other side. So this completes the tone assessment. At the end of tone assessment, we comment whether the baby's tone was normal or abnormal. So whether it was normal or hypotonic or hypertonic. If there was an abnormality, whether this was symmetrical or involving the trunk more or the appendicular tone more. So axial versus appendicular. And if it is appendicular, it's also important to say whether it was involving upper limb as well as lower limb or both. Sometimes we may have selective involvement of active versus passive tone or equal involvement of both. So in conditions like drug toxicity, like overdose of phenobarbital, or just in a baby who has got regular dose of phenobarbital, we expect passive tone to be more involved than the active tone. So the final part of the assessment would involve the assessment of deep tendon reflexes, as well as comment on clonus. In deep tendon reflexes, we don't elicit all the reflexes in a newborn baby. Typically, we only look at the knee jerk. So for knee jerk, we do not need to actually use a knee hammer. A stethoscope might be more than enough. So you can use the bell of the stethoscope, keeping the knee in mild extension, and allow the baby to come to the neutral position. And you will be able to see mild degree of, you saw regular knee jerk now. The baby will respond by extension of the knee. And we just saw the Babinski sign, which there is a response to the plantar reflex. Some babies may exhibit clonus physiologically. So if you suddenly dorsiflex the sole, you may sometimes see multiple jerks. Presence of ankle clonus is not abnormal in a newborn baby. So we have finished assessment of higher mental functions, cranial nerves, as well as motor system. Sensory and cerebral examination is not possible in a newborn. We also need to include the assessment of fundus as well as measurement of head circumference, comment upon the shape and the size of the head, as well as comment upon the spinal cord or the back of the baby to complete our central nervous system examination. So thank you very much. We will meet with another session next.